Okay, so we are back live, the Senate Health and Welfare, and we're looking at H72, which is the overdose protection site, so harm reduction response to drug use. And Dr. Levine, thank you for being with us today. I hope you didn't have to drive in the snow to get where you are. Here
I
we
did
are.
not, though I very much regret not being able to be in person, but thought the better part of valor was to avoid driving through the mountains.
Thank you. Okay, good. So we're looking at H72, and I believe you did testify in the House on the bill. On the
A
overdose.
year ago,
Yeah, okay. So why don't you introduce yourself to the record and then offer your comments on the bill and on overdose protection sites generally? Then we'll probably have some questions for you. I know I do, and I know others will as well.
I'm sure you will, and I do have some comments. I'm Dr. Mark Levine, Commissioner of Health, and thank you so much for allowing me to provide testimony on overdose prevention centers today. So one thing we've learned from years of working to address the complex challenge of preventing overdoses and deaths is there's no one-size-fits-all solution. It's crucial to consider all evidence-based options that are proven effective. Public health practice indicates the most effective way to address a health concern, including overdoses, is to ensure a comprehensive set of strategies to meet the needs of those most impacted by the health concern. The nuances of if, where, and how to introduce opioid prevention centers are important, and whether they're appropriate for a rural state like Vermont and would work here is the million-dollar question. As you'll see in my comments, I'm trying to be a thoughtful clinician and public health leader, and frankly, I have struggled with this question. My position is framed by a review.
Dr. Levine, Commissioner, I apologize to stopping you in your flow, but we do not have your comments on our webpage. Would you mind?
You will at the conclusion, I believe.
Pardon me?
You will have them by the time we're done.
Okay, great, thanks.
Can we have it louder too?
Sure.
Oh,
It's up as high as it can go.
Muffled.
Okay, so in terms of the audio, perhaps you could speak closer to the microphone. There you go. That's great. You're in the room with us. Okay.
How does this sound?
We'll hear you.
Heritage.
Go ahead. Let's hope it works.
Well, just stop me if it proves challenging. So, as I said, I've struggled with this million-dollar question. My position is framed by an updated review and critical appraisal of the literature. And that position is that while I acknowledge overdose prevention centers can have many potential benefits and be part of a multi-pronged approach to the opioid epidemic, they ultimately may not represent the best option for a state such as Vermont at this time. I'll spend the rest of my time exploring with you how I arrived at this conclusion and the challenges and data I took under consideration. It is not my intent here today to repeat all that you've heard from researchers about the evidence base, but I do want to state that there is a difference between what we call internal validity of a study. Are the results valid for the population studied? And external validity, also called generalizability. Are they accurate for other populations like Vermont? I respect the opinion of the Opioid Settlement Advisory Committee, of which I'm the non-voting chair. These are smart and compassionate people. I recognize OPCs can be considered to be part of a continuum of harm reduction services and part of this so-called multi-pronged approach to reducing opioid overdose deaths. Helping people stay alive so that they can get the treatment and supports they need for recovery is always our highest priority at the Department of Health. Now, the major reason cited for support of OPCs is Vermont's current opioid overdose death rate. The ultimate test is, do they save lives? Now, we know that deaths within a facility are rare, and there seem to be improvements in fatalities in the immediate neighborhood, although Dr. Marshall et al.'s study, the only study of at least moderate quality to demonstrate this, is over a decade old and prior to the fentanyl crisis. We should be concerned that there is no evidence that accessing a site lowers an individual's risk of fatal overdose over time, or that sites lower community or regional overdose death rates. Studies report no consistent impact on community fatality rates, as they cannot control for the lethality of the drug supply and the combinations of drugs used by clients. Now, I continue to be very troubled by the vast experience of Vancouver and British Columbia, where overdose numbers continue to climb, where the overdose death rate is 44 per 100,000, compared with Vermont, 37 per 100,000, despite there having 44 overdose prevention centers. And they've now adopted a strategy called Safer Supply, which includes things like prescription heroin. And for Vancouver Coastal Health Authority, where downtown Eastside is located, that's Insight, 2 other safe consumption sites, and 9 OPCs, their overdose death rates per 100,000 started at 39.7 in 2020, gradually increased to 50.8 in 2021, 52.2 in 2022, and 55.9 in 2023. And overall, in British Columbia, there were 2,511 suspected unregulated drug deaths in 2023, which is the highest number they've ever recorded in a year, and 5% higher than the preceding year. Now, having said all that, I do want to acknowledge there are potentially favorable outcomes. Similar to the experience with syringe service programs, frequent OPC users have safer injection practices and shorter duration hospitalizations for injection-related infections. There's increasing evidence, most recently from on-site in New York, that government-sanctioned OPCs are not associated with worsening crime or disorder outcomes, or increased community drug use, or use in public spaces, and may be associated with decreases in injection-related litter. OPCs can increase access to healthcare and provide another potential pathway to treatment, as they serve as a trusted community that leads to improved overall well-being. There are many more qualitative outcomes that are difficult to measure that have also been proposed, such as humanizing people through providing essential services and improving sense of self-worth. And I don't want to minimize those. What is somewhat challenging to reconcile here are some significant potential limitations that may impact the effectiveness of sites at this time in Vermont. First, in the fentanyl era, use is frequent and occurs around the clock, challenging the success of OPCs, which are generally not open 24 hours, especially if they are to save lives. Next, one cannot reasonably cite sufficient OPCs to meet demand outside of high-use neighborhoods or in rural areas, and we do not have yet an accurate representation of demand. Next, while sleep and personal hygiene can be favorable outcomes from daytime use of these facilities, OPCs are generally not open 24 hours. I recognize we are now in a syndemic of substance use disorder, mental health crisis, public safety crisis, and homelessness. These facilities are not meant to reduce homelessness, and that will remain problematic in the surrounding neighborhood. Finally, the services provided by the facilities are resource intensive and necessarily limited, both geographically and temporally, meaning most Vermonters with an opioid use disorder will not have access to the benefits these facilities may provide. As I've said all along, while not a panacea, OPCs play a useful role in a continuum of services for people who use drugs, but they cannot and will not reduce the overall burden of tragedy. And they certainly do remain an evidence-based prong in a multi-pronged approach to harm reduction. I'm concerned that expectations are often unrealistic and must be managed carefully. Now, finally, I do want to comment on studies in more rural areas, mainly Canada, of mobile OPCs. Now, if saving lives is indeed the metric of greatest concern that might potentially differentiate OPCs from other harm reduction strategies currently in use, it's still not clear how an occasional visit from a van can produce desired outcomes in a condition that by definition requires frequent use, as well as maintaining continuity and quality of services. Now, there's limited research about these in rural settings. A 2022 recent analysis, Panagiotoglou, analyzed the population level effects of overdose prevention sites and safe consumption sites at the local health area level in British Columbia from 2015 to 2017. The sites were implemented 1 year prior in 2016. These local health areas were defined as covering geographically dispersed clients. Some of them had populations that were smaller than Vermont cities, in the teens to lower 20,000, and were considered rural or remote. The results were, quote, significant declines in reported overdose events, paramedic attendance, and emergency department visits were observed. However, there were no changes to trends in monthly hospitalization or in mortality rates, end quote. So in a rural state like Vermont, we've already seen how many barriers there can be to accessing services. These include, but aren't limited to, hours of operation, transportation, comfort and levels of trust, safety concerns of the community, expectation of privacy and safety, and the ability to recruit and retain staff. Availability of workforce in the substance use system of care is currently a major issue in Vermont and has impacted the viability of programs and the accessibility of services. The committee should not lose track of the fact that syringe service programs are effective community-based programs that can also prevent infectious diseases, link clients to treatment for substance use disorders, and might reduce overdose deaths among people who use drugs. We do have mobile SSPs in Vermont, and they do work, and expanding their scope makes sense. Now, ultimately, I question the appropriateness of OPCs for Vermont. They may work best for communities where people who need these centers can access them easily and quickly. Typically, these tend to be larger population areas, neighborhoods where injection drug use is more prevalent, similar to how New York City actually cited its 2 OPCs. They almost always serve an area of blocks rather than miles. People should never drive to the sites. It's challenging to cite sufficient OPCs to meet demand outside of high-use neighborhoods or in rural areas. Citing OPCs in more rural areas may result in people driving to them and then driving home while impaired. While the requisite density of potential clients is a significant ingredient, there are 2 other ingredients that are essential: community support and political municipal leadership support, along with planning around related issues such as medical care, management of syringe waste, ensuring people are safe when they leave a facility, and the development of the appropriate regulations and guidelines. We're already seeing conflicts regarding these play out in communities like Brattleboro. The Settlement Advisory Committee has not seen communities lining up with expressed interest other than our largest city, Burlington, and cost effectiveness in rural areas is unknown. 2 other challenges I'd like to note. The first is transportation. Vermont doesn't have the population density of people who use drugs and sufficient public transportation to facilitate them consistently using the site. That gives people who don't live within walking distance the option of lingering near or in the site, having a designated driver, driving after use, which is completely unacceptable, setting up shuttles to transport people, which apparently Rhode Island is planning to do, or not using the center at all. If people attend a site and then drive, consider who might have liability. Finally, equity in a rural state is critical when rolling out any new and resource-intensive harm reduction strategy. While Burlington might enjoy the triad of a high-density neighborhood, community support, and municipal leadership support required for success, it's obviously much smaller than the other international locations, as well as New York City. And the location of the next US site, Providence, Rhode Island, is almost 5 times as populous. This suggests there will be challenges citing further OPCs in Vermont municipalities or rural areas if one accepts the thesis that mobile capacity is unlikely to be frequent enough to save lives in a condition requiring dosing multiple times per day. And keep in mind, our highest overdose death rates are in rural counties. Health equity is a consideration in virtually every public health decision we make in Vermont, and OPC should not be an exception. I want to acknowledge a few other pieces of data before I conclude. Although we need to wait until late April for our most comprehensive numbers, opioid overdose deaths for 2023 in Vermont do not appear to be significantly different from 2022. We're not seeing the large increases we've seen for 2 successive years. There may well be a plateauing of deaths and a departure from these increases. Possibly this indicates a maturation of prior and recently added harm reduction strategies. Additionally, if we ignore deaths and just look at overdose events, for the last year now, they have been consistently below the prior years. Now, I'm not stating all this as wishful thinking or to minimize the ongoing crisis, but to point out that over the 2 to 3 years interval between now and the opening of an OPC in Vermont, new trends may occur, and we may see current evidence-based harm reduction strategies come to fruition. Another piece of data I want to share is that the overdose crisis is evolving in new ways. In British Columbia, the most common route of opioid administration and deaths now is smoking fentanyl. A recent CDC report shows that from 2020 to 2022, the percentage of overdose deaths with smoking increased 74%, and the percentage with evidence of injection decreased 29% across the entire country. Changes were most pronounced in deaths with illicitly manufactured fentanyls detected, with or without stimulant detection. Our experience in Vermont is similar. In 2019, the most common methods of use were intravenous, 51%, snorting, 24%, ingestion, 22%, and smoking, 15%. Intravenous decreased from 51% to 41% in 2020 and to 37% in 2021. Smoking increased to 29% in 2021. Snorting increased to 20%. Such considerations add new concern. Allowing inhalation in an OPC, which has been done, but still maintaining the safety of the workforce in such an environment. Dedicated rooms to allow for smoking may change the design and expense and other logistical considerations in planning a safe facility. Final piece of data, since over 40% of people in Vermont who have died of an overdose are alone when they die, and a high percentage die at home, use of monies to address drug tracking machines or promoting new technologies or programs such as neverusealone.com might represent a compelling alternative strategy. A thoughtful assessment of how to use finite resources is imperative, We know that directing funding to the operation of OPCs means there will be fewer resources spent on other Vermont SUD programs with demonstrably successful track records. In my concluding remarks, I'd like to voice a few concerns VDH has should the legislature adopt this legislation. First, the money for research is inadequate. We've talked with the New York City and Rhode Island research team, New York, Langone, and Brown. They're being funded by NIH at $1.4 million per year over 4 years, as opposed to a total amount of $300,000 in H72. If we have a contract in place on 12/1/24 as proposed, it may be years before the sites are open and can be evaluated, which will result in an extended period of baseline data collection and decreasing the time available after implementation. We would recommend the contract start date not be included in the bill to reflect the variability of start date of the OPCs, or at least delay it to the same date as the completion of the guidelines, April 1st, 2025. The sites will have to apply and VDH has to approve within 45 days. The funding we would recommend should be increased significantly to $300,000 per year with an actionable research-based evaluation is what is designed. Second concern, the administration is against using the Education and Research Fund rate increase mechanism for funding these. And lastly, the literature is clear that stakeholder involvement in planning is critical to ensure greater uptake and should be incorporated. There are many individual preferences, and planning must include information from the community to understand where an overdose prevention center could be located, what services might be offered, what partnerships are needed in the community to allow it to be successful. Also consider what other harm reduction strategies might be prioritized to optimize the use of limited resources, such as increasing methadone access, transportation remedies for hub access, improving transitions of care after incarceration, etc. And I would ask somewhat rhetorically, is sacrificing primary prevention activities a wise precedent to set for use of opioid settlement monies? So thank you for allowing me to acknowledge the potential benefits of OPCs and their place in a multi-pronged approach to harm reduction, and to point out the concerns I have with their impact and what should be the most critical indicator of success, mortality. And finally, to discuss all the factors that have led me to conclude that these may not provide sufficient benefits for all Vermonters with opioid use disorder at this time, including poor generalizability of existing studies to rural states, issues of access to sites that are traditionally neighborhood-based, transportation, and health equity. I suggest you factor into your decision-making the evolving overdose data in Vermont and the data surrounding routes of ingestion of opioids and the large percentage of Vermont overdose deaths occurring alone and in homes. I'm happy to take any questions you might have, and I hope you heard everything I said.
We heard everything you said, and we look forward to having your testimony on our webpage, because there was a lot there, including some suggestions for the bill improvement as we look through the bill. I do have a couple of questions to get started, and then I know others may have questions as well. So I did hear you say that there were considerations that should be made if we go forward with, or if a locality, a municipality goes forward with establishing an OPC. So you have recommendations in there about collaboration at the municipal level, and then some of the concerns that you would have about the Department of Health involvement in oversight and regulation, and then the outcomes determinations that you would want to see with a pilot program.
Yes.
Okay, and then, so that was one of my questions actually, is that this is a pilot program and may well answer concerns about does it fit with who we are in Vermont. and may open up opportunities to look at the transportation question that you raised and others. So your comments are well taken. My second question was about the funding level, and you indicated $300,000 would be appropriate for each. If we had two in the state, then it would be $600,000, or are you suggesting $300,000 for both pilot programs together?
I would think for both, 300,000 per year as opposed to 3,000 for the entire lifespan of the intervention.
Okay, so if $300,000 is set aside, that would allow for two pilot program sites to go forward.
Yes, and I completely understand why Burlington is considered, for the reasons I mentioned, as a potential pilot site. Although I would wonder if the committee has heard from any other parts of Vermont interested in becoming a pilot site, and where such a site would be, knowing that we have no other community that has the size of Burlington, which frankly, as I pointed out, is still on the small side when it comes to experience with these.
Right, I don't think we've heard from any other municipality or town or city that has delved into it as much as Burlington has. And we are hearing from Burlington tomorrow. I do have another question for you. You identified the opioid settlement fund as a more appropriate source for the funding. I think I would agree with you on that, and that it would mean taking the other fund, the manufacturer's fund, out and replacing that with the opioid settlement fund. Having said that, I know that we have in process and legislation that allows for the advisory committee to make recommendations, and then those recommendations to go forward through the budget process. So is your suggestion that we recommend the opioid settlement fund as the appropriate place should this go forward?
You're going to be receiving a separate communication from the Opioid Settlement Advisory Committee, which I presume will make that very recommendation. That's not necessarily the administration's recommendation when we, as I just presented, commented on the appropriateness or lack of appropriateness of this initiative for Vermont. So all we know clearly is that the Evidence-Based Education and Research Fund tariff increase, if I could call it that, is not being regarded as the optimal place.
Thank you. Okay, thank you for that. Oh shoot, I have another question for you. I guess the question is this. The pilot programs really would, if there were sufficient research, as you've indicated, would help us understand the regulatory process here. If we don't put anything into legislation, is it possible that a municipality could open up its own OPC?
I would say nothing is impossible, but I cannot believe any responsible municipal leadership would allow that to happen, knowing that the idea of the legislation, and indeed the legislation that occurred in Rhode Island, though not New York, was to first remove any liability to those who might frequent a site or those who might participate in the operation of a site. So I can't see one proceeding forward without the appropriate legislation to remove those liabilities.
Okay, last question for me. Well, it's not my last question, but just in thinking through the pilot project and your concern about transportation, what thought might you have given to having a mobile center?
Yeah, some of my comments did concern that. again, first of all, the metric of will it save lives? And I'm saying this not because I'm callous or not empathetic about an individual life being saved on an individual experience from one overdose within the mobile center. But I'm saying this on a public health population-based basis, where, as I pointed out, the data just isn't there to support that. And in fact, the data from Canada is to the contrary, that deaths continue to increase from overdose deaths. So while I have that in the back of my mind, I think it's also very challenging for me to understand how a van that might show up in a community periodically, and I don't know what that periodicity would be. Would it be twice a week, once a week, what have you, could possibly be successful in saving lives, even if it does do many other important things, as do our mobile syringe service programs, in terms of creating the trusted community, providing syringe exchange, perhaps, providing resources that might help connect people to treatment, etc. So I don't want to say that none of those might occur, but they will not occur with regularity. And we already have a mechanism for most of those things to occur with the SSP program.
Okay, thank you. I do have one comment. I know that you feel very strongly about primary prevention and that this doesn't appear to be primary prevention, although we could consider it that as preventing death. It is harm reduction, we do know that. But it's very interesting to me that when we have an opportunity for primary prevention, that a bill is vetoed. So I'll leave my comment at that. And I'll allow for others to ask their questions.
I understand your intent with that comment.
You understand it, and it's really significant because the more we attempt to have primary prevention in place, the less support we get for it, and it's extremely disturbing. Okay, so Senator Hardy has a question.
Well, to just carry on with that theme, Commissioner, you expressed some concerns about the timing and how this would take time to implement, and essentially saying by the time we implement it, deaths, the things might be different. Well, had this not been vetoed multiple times, we would be further along in the planning and the data collection and the implementation of something that could have already saved lives. So I agree with the chair. This is incredibly frustrating that when we try to put into place harm reduction and preventative programs, they are vetoed by the governor. But I wanted to clarify your question, because your concerns about the research funding, and in regards to the question from the chair. So I got confused with that exchange. You're suggesting $300,000 per site a year for the research. Is that what you said? Could you clarify?
If there were 2 sites, I would still think $300,000 per year for the package would be sufficient.
Okay. Okay, $300,000 per year for just the research part of it, not the operation or implementation. Is that what you're saying?
The research and evaluation piece.
The research and evaluation, and that you suggest not starting that contract until the site's actually open. Is that correct? Is that what my understanding?
Either until the site's open or until that period of time that, for the legislation, is when the guideline process has been completed, which is April of 2025.
Okay. Yeah, it would be really helpful to have your testimony in writing, because it was a lot. But I also want to push back on your assessment of the data from Canada. I don't have that data in front of me, but I believe we heard testimony in the opioid settlement committee that when you look at the granular death rate for the location where the opioid overdose prevention site was or center was, in that area, there was a lower death rate than broader. So yes, broadly, the death rate didn't decline, but in the specific area where the center was, it did. That's my recollection of that data. So I think you're broadening it out too much and not acknowledging the fact that there were a lower death rate where the centers were located.
Yes, that was Dr. Marshall et al. 2011 study that showed an improvement in fatalities within 500 meters, which is about 0.3 of a mile from the facility, but nothing broader than that. And my concern is that's really the only study that's done so. Hasn't really been replicated, but quality studies. And it's well over a decade old and prior to the current experience with the fentanyl portion of the epidemic.
Okay.
Just a comment, if you refresh, you'll
Is
get
it?
the testimony.
Okay.
Kiki just put it up.
Okay.
Kiki and Olivia are having a tag team event.
Nice.
Go ahead.
I'm gonna look at the testimony and
Okay.
maybe, so if Senator.
Oh, no, I just had a quick one.
Yeah, go ahead.
Thank you, Dr. Levine. We can talk about deaths going up, but is it not plausible that without the OPC, they would have gone up even higher? We're kind of creating this binary, but it seems like it might be more complicated than that.
It is always plausible, as you say, that that could have happened. Absolutely. But it still is quite concerning that they went up at all. But I do understand where you're coming from. You know, I have been criticized by advocates who say that since I've been health commissioner, deaths have gone up in Vermont due to opioid overdose. And I agree with that. Whether that is a association that my presence in the commissioner seat has led to that outcome, of course, is a different thing to argue about. And indeed, prior to the COVID pandemic, deaths were going down in Vermont. And the pandemic provided a position of stress on that. So there are always multiple factors at play, for sure. And the major factor at play in 2024 is the toxicity of the drug supply. And no one will deny that.
Thank you. It's complicated.
There always is.
Senator Weeks.
Thank you, ma'am. Thank you, Dr. Levine. I appreciate your testimony. As always, I find you very balanced. You're looking from all perspectives on all issues, and this one in particular, I certainly appreciate it. A couple questions. First, at this point, from the perspective of injection sites, has there been any data on the percentage of those that use injection sites who ultimately enter into treatment options?
There is some literature, and the existing literature says somewhere in the 40% range may actually enter treatment. That's being selective in studies. It's not an outcome that has been measured across all studies. It's also not a consistent outcome. Not all studies have shown the same, but the studies that have shown a difference have shown up to 40% engaging in treatment. Now, most of the time, the metric used is, did the site provide an offer of treatment to someone? And it's a little harder to get at, did they actually access treatment? Did they maintain their presence in treatment, have some kind of success in treatment? So you have to be very careful about understanding what question was asked. Was it just, is the site doing its job? by making sure they try to connect everyone with treatment versus is the site actually succeeding because people are connecting with the treatment. The 7 Days article had one point that came out that was criticized, which is that individuals, Mr. Rivera, who runs the on-site in New York City, basically said, we don't keep harassing people by talking about treatment. And people felt that, well, they should. He was making a point that, we're trying to do a lot with our clientele, and not necessarily every moment we get are we asking them to go into treatment. But others have confidentially said to me, well, that seems like malpractice. Why aren't they doing that all of the time? That should be their goal. So depends how you look at it.
Okay, thanks, sir. And then following on the same question, is there any data on the percentage of injection site users who lead to sobriety, not just treatment, but so let's just assume that 40% is somewhere in that ballpark. Is there another statistic about those that gain sobriety?
I'm not aware of any such statistic. Keep in mind, sobriety is an elusive concept too, because we're talking about a chronic condition where even in the best of circumstances, some individuals will have revert back to their drug use. But that doesn't mean in the big picture, they're not going to be successful in the long term, even though they've had episodes where they've gone back to using their drugs.
Right.
So again, these are very challenging measures to make.
Right, yes, sir, understood, thank you. And then you mentioned a NIH study or NIH report. Is that a study of injection site, the concept, or what was their effort?
No, that's not coming from injection sites. Are you talking about the smoking versus injection or a different report?
Okay, well, let me rephrase the questions, because you mentioned something about NIH, and I latched on that, which I'll research offline, but are you aware of any federal studies in the topic of injection sites and pros and cons and success or otherwise of the concept?
No, because so far all we have is the 2 sites in New York City. So they are undergoing an NIH-funded research analysis, which has not yet come out with peer-reviewed literature, though there are plenty of news reports. So we're awaiting data from that analysis. But that's the $1.4 million per year over 4 years that the NIH is kicking in to evaluate both the New York City sites that do exist and the Rhode Island site that is still yet to open.
Thanks, sir. Thank you.
Okay, good, thanks. Go ahead, one more and we'll
Yeah,
because you've given us a lot of testimony that we need to evaluate, but go ahead, Senator.
thank you. Commissioner, it seems a little contradictory that you mentioned about how the data show that people are dying because they're using a loan, and yet you're not supportive of a facility that would allow them to not use a loan. We got really heartfelt and difficult testimony actually from someone with lived experience who was on the opioid settlement committee with you and I, who talked about using a loan in a parking lot. And had she had the ability to go to an opioid overdose prevention site, she wouldn't have been using a loan. So I think it's contradictory, and I don't understand. I'm supportive of things like the Never Use a Loan site and that the phone bank as well, but this is another tool for people to not use a loan. You acknowledge that people are dying because they're using a loan, so I don't understand how you're reconciling that.
Yeah, and one of the things I said is we don't really have a sense at this point in time for what the demand is and how many of these individuals who have an opioid use disorder and or use at home or use alone would frequent the site. There's no question that many might, so I don't want to minimize that. But at the same time, we have a real problem in Vermont with use alone and often at home settings, which is where the site of death often occurs. So we do need to be very expansive in how we think about what role these sites might play versus the other interventions you mentioned that our committee unfortunately only had a brief moment in time to think about because it came at the very end of our deliberations in 2023. So I consider, again, these may be complementary as opposed to one might be better or more appropriate than the other. We often just don't know at this point.
Okay, thank you. All right, so this is a lot of information. You've also, and what I thank you for adding suggestions that might improve the bill. I think at least it seems like for the majority of the committee, there's an interest in continuing on with the bill. We'll be looking at it and certainly consider the suggestions that you've made, and especially with respect to funding and outcomes. Thank you very much. So what we're going to do now is Michelle is here, and Michelle, I think you have a draft. New draft.
I do have just some reorganization language.
Yeah, let's look at that. We'll look at that really briefly, and then we'll hear from Nolan. Because we have time. Emily Brown, who is going to testify on 66 has lost electricity. I don't know where she lives, so she got it back. She just got it back. Okay, so we'll just spend a short time looking at that, and Nolan briefly about finance. And we'll come back to 721 and 233 on the financial piece of it as well. Jensen. So, and one thing I would suggest to the committee is, as you look through Dr. Levine's comments, consider potential improvements to the bill that, might expand the bill or might offer guidelines or regulations if and when a pilot is established. And then also, the never use alone line, that there's a link in his testimony. And then the other piece of it is the funding.
All right. So, sorry, I see that it says the Committee on Government Operations, and I don't know if that was just a typo that I stuck in there or, but so it's that, ignore that.
We have not done anything on that.
Hold it. Well, it does have municipal stuff in it.
Yeah.
I think they're right next to each other on our template when we do that.
Don't worry.
Sorry about that.
Alphabetical.
So, for the
Planning
record,
committee is a good.
Michelle Childs, Office of Legislative Counsel. So I'm just gonna kind of show you the way that I've restructured. So I discussed a little bit in our,
There we go.
We're offline. We- We're our return, so, and I'm reluctant to say go off live because we might really lose it.
Okay,
You
it
just
looks like
lost.
we